Good afternoon. Dr. Tan gave a very balanced introduction and overview of prostate cancer, especially in a localized setting. I will continue on from here. Some of my points may overlap, but I'll highlight things that have not been touched before. So we know prostate cancer is the most common cancer in Singaporean males, but that has not been pointed out before is the chance of being diagnosed with prostate cancer at stage 4 in Singapore is about 30%. Okay, so that's still a very high rate, and this is based on most recent data. And it's similar in neighboring countries like Malaysia and Indonesia. So we want to think about how we can diagnose more patients at earlier stage, and a lot has been talked about this PSA blood test that represent prostate cancer, PSA blood test that is not prostate cancer specific, that can be elevated in other non-cancerous conditions, including benign enlarged prostate that comes with age, any prostatic inflammation, rigorous exercise, or even sexual activity. So quite commonly, I will tell my healthy patients that if they ever consider PSA blood test, perhaps refrain from rigorous exercise like riding a bike for 10 kilometers, heavy running, or sexual activity for at least a few days before they take the blood test, so that we have less borderline raised reading that cause alarm. In terms of recommendation for PSA testing, in fact, MOH doesn't have a very strong statement about recommending patients to undergo PSA testing routinely. They should speak to their healthcare providers and only consider if certain criteria are met. For example, age 50 to 69 is what the American guidelines will focus on. And ideally, they should have reasonable life expectancy so that it's worthwhile to screen for the cancer and intervene before other health condition overrides that. Now, I want to point you all to this document that you can Google. It's published by Singapore Cancer Society. And I think it's a very balanced overview of the pros and cons of PSA testing. There's a reason why it's not recommended with very strong statement, but as long as you read through this document, you will understand what PSA is about. Then you can approach this testing with a much clearer mind. Because if you abandon PSA testing completely, what you're going to see is a major shift in stage 4 prostate cancer diagnosis in your society. So you can Google SCS, should I be tested for prostate cancer? So my role is medical oncologist, but the care for prostate cancer is not delivered by me alone. We probably will require intervention from various other specialists, including surgeons, Dr. Tan, radiation doctor, and even our allied health doctors such as continence nurse, physiotherapists, and sometimes even genetic counselors. So what's not been highlighted is you can be in different phases of prostate cancer. So the light blue box is the localized prostate cancer or locally advanced prostate cancer. Dr. Tan talked about different grade groups, grade 1 to grade 5, and these patients can have definitive treatment or active surveillance. The high-risk group, some of them may relapse even after definitive treatment, perhaps in the rate of 20 to 30%, and that will end up in the dark blue group where they have detectable PSA after treatment, so-called biochemical relapse. Those patients can be subdivided into the dark purple group, whether they have high volume disease or low volume disease. And occasionally, as I mentioned, in Singapore, 30% of patients will be diagnosed with stage 4 cancer right from the beginning, the yellow box, the de novo metastatic prostate cancer. So all these situations will warrant different treatment approach. There's no one size fits all. There are various drugs, various surgery techniques, various radiotherapy techniques, but it depends on where you fit in the box, okay? I won't touch too much on this, that's been covered before. But I'll talk about different drugs that we have in prostate cancer. First and foremost is something that's been well established for many years called androgen suppression therapy, ADT, and that can be in the form of medical suppression where we give drugs to suppress hormone directly in the body. In the old-fashioned way, sometimes it can be done surgically, doing a surgical castration. Then there are various drugs classes that's listed after that, including the most widely used drugs now called androgen receptor pathway inhibitors. There are a few listed there. The abbreviation is RP. And then we still use chemotherapy for prostate cancer in select groups of patients. And there are newer drugs such as targeted therapy using drugs that block DNA repair defects called PARP inhibitor. And then we have a unique treatment similar to radiation therapy, but in its form is an injection type radiation therapy that's labeled, and it will seek out cancer cells and deliver the radiation at where the cancer sites are sitting. Immunotherapy plays a small role in prostate cancer treatment, specifically for a very small group of patients that had unique alterations in their cancer cells that represent about 2 to 3% of our patients. One point to make is prostate cancer is a cancer of elderly, unlike breast cancer, where we may see very young patients in the 30s, in the 40s. Prostate cancer average age is in the 60s, some may be in the 70s or 80s. But a lot of these drugs can still be delivered even when they are of advanced age, and sometimes we may even deliver them in combination to fit certain situation. So 3 themes that I'm going to touch today. First thing is talking about this PSMA, that stands for prostate-specific membrane antigen, and we can use it for accurate diagnosis and delivery of treatment. The second point is how we intensify treatment for better results for certain groups of patients at higher risk of relapse and recurrence. And the third thing is using targeted therapy based on genetic testing results. I'm going to start with one case here from quite a few years ago. This is an elderly chap who has minor health issues, but he was quite fit. He came into emergency with difficulty passing urine, and the urologist who looked after him did a few tests, including PSA at that time, which was very high at 360. Normal cutoff is less than 5. He had a procedure called TURP to open up the urinary channel, and at the same time, a bit of flesh was taken out during the TURP procedure and was submitted for testing, and that confirmed cancer in the prostate, very high grade, Gleason 5+4. The MRI scan at the bottom basically highlighted the size of the prostate, which was very bulky, but interestingly, despite the very high PSA reading, the lymph nodes around the prostate were not swollen. The bones around the prostate looks quite normal. So we're not sure whether this is stage 4 or not, and some patient went on to have a scan to look for cancer spread. Prostate cancer typically spreads to bone, so for this cancer, sometimes patients still receive a scan called bone scan to look for bone metastasis, and if there are bone metastasis, you will see very dark shadow in the skeleton. The only dark thing is the kidney, which is normal, so this is considered a normal scan. But we still have an unexplained raised PSA. So he went on to have a more accurate scan called the PSMA scan, which highlighted a few spots that's actually quite small, that pointed out in the white arrow, some in the pelvic bones, and then a few small lymph nodes on the left-hand side of the screen. So he actually has spread of cancer beyond the prostate, and if he has undergone a surgery or radiation just targeting the prostate, ultimately the long-term results will not be favorable as well. So the final impression for this case is, in fact, he has metastatic cancer, not seen on the basic imaging, and he avoided an operation, and he started on some treatment to help with his overall stage 4 cancer. The take-home message here is not what treatment to give, but when to consider PSMA PET. This scan is quite expensive. It's not 100 or 200, it's a few $1,000s. And we can't go around doing PSMA PET for everyone because of cost issue. So we'll strongly recommend this scan for anyone with PSA level more than 20, or the higher grade cancer, Gleason grade 5, or the T stage 3 or above actually. Staying on the PSMA theme, so when we talk about PSMA, it basically is illustrated on this cartoon here. The prostate cancer cells are highlighted in orange and red, and what you see on the prostate cancer cells are these little blue things, which are proteins expressed on the prostate cancer cell surface. Now we can design test to look for where the cancer sits by labeling something that will stick to this blue PSMA on the surface of the prostate cancer cells. Similarly, we can design something to deliver radiation. So you can see on the light blue thing, that's a radio emitting agent called 177 lutetium that's tagged onto PSMA 617 that will stick onto the blue item on the prostate cancer cell surface. So patients with PSMA positive PET scan will benefit from this treatment delivery where radioactive energy can be delivered straight to the site where cancer sits actually. This slide basically shows 8 sets of patients with picture pre and post treatment. Not my patient, these are published in medical paper. So you can see the left hand picture will have a lot of red signals. The right hand picture will have quite clean signal. Basically, red means cancer cells deposit. Most of them have quite good response because the baseline scan showed a lot of sites that have very high expression of PSMA. Second theme that I want to touch on is who should receive more treatment, not just treatment to lower PSA. A lot of treatment can lower PSA, but how much is the ideal treatment? So this patient also was from quite a few years ago, middle age. He has a lot of health issues and hasn't looked after his health because he was busy with his F&B business. So over the years, he actually had raised PSA. In fact, 2 years before diagnosis, his PSA was 25, but for some reason it wasn't followed up very closely. But by the time he presented in September 2015, he actually had back pain from cancer spread. At that time, the biopsy of his prostate also confirmed prostate cancer, high-grade Gleason 4+5, and the scans at that time were not normal. So this is another set of bone scan, but this one is different from the first scan. You can see there are some black spots in the ribs and some black spots in the lower spine, confirming the cancer has spread, and he also has some swollen lymph nodes on the CT scan. So the impression is he has stage 4 cancer at presentation, and unlike the other men, he has much more disease. And the question is, what is the minimum he requires for best long-term results? In the old days, all these patients would just receive single therapy with androgen suppression, ADT. And if we start these patients on hormone suppression therapy, the chance of PSA drop in the coming 2-3 months is in excess of 90%. But it's not durable. On average, about 12 to 15 months later, we're going to see a PSA rise, and patients will be recommended to start another type of treatment such as chemotherapy. So there's data to show that adding chemotherapy early, before the PSA even rise, for select group of patients will lead to much more durable results. And we only need to give a course of chemotherapy over 4 to 5 months. So he received that despite his other health issues. And this is what his PSA has been doing. Between 2015 at diagnosis and 2022, his PSA stayed very low. In fact, the last reading I had up from him before I passed his care to my colleague was 0.9, which was very low. So this slide illustrates how we have changed our mindset in looking after stage 4 prostate cancer. So in the old days, I said they all received just hormone suppression therapy. But in 2015, there was a big paper that came around showing early usage of chemotherapy, just different time point, same side effects, or perhaps less because patients are fitter at that time, results in much better overall survival, much better duration. Patient remain well without symptoms from cancer. When that paper came out, there are some patients who were not suitable for such treatment because not everyone is suitable for chemotherapy for various reasons. We greatly welcome new data that came around subsequently where this new class of drug called RP, androgen receptor pathway inhibitors, came around, showing if you add ADT with RP, which are tablet forms of intensive testosterone blockade, we also achieve very similar results. In the past 2 years, instead of doing doublet strategy, there are some patients who will derive benefit from triplet strategy, ADT plus chemotherapy plus androgen suppression using RP. Now, those are treatment based on seeing how many dots on the scan. Not much understanding of cancer biology. In the coming 5 years, I think more and more we'll try to tailor treatment based on what we understand on the cancer cells biology. What is the alterations that driving this cancer? So there are data published on DNA repair alteration, where adding targeted therapy with PARP inhibitors to this strategy may enhance efficacy. There are other alterations such as PTEN loss that has specific drugs designed for it. So this space will evolve in the coming few years. I also mentioned that for high-risk prostate cancer, Gleason group 4 and 5, for example, node positive or PSA very high, 40 and above, or stage T3 or T4, these patients are at high risk of relapse. 20 to 30% of them may relapse after initial radiotherapy or surgery. For those patients who receive radiotherapy as part of their treatment, we have data to intensify treatment, not just using androgen deprivation therapy, hormone injection add-on for 6 or 24 months. These patients will have benefit by adding additional drug. In this particular case, abiraterone, which is an oral tablet. It enhances metastasis-free survival by 47% and overall survival by 40%. The last theme I want to touch on is targeted therapy in prostate cancer. So there's this particular gene alteration, not just one, but a set of them that is responsible for DNA repair in our body, not just specific for prostate cancer, but in other cancer. So when you have alteration in DNA repair gene, it cannot effectively repair day-to-day DNA stress that we have in our body. And when these DNA alterations that's not repaired effectively accumulate in our body, we get a clone of abnormal cells and we get cancers. So how common is DNA repair genes in prostate cancer? If we go back 20 years ago, we don't have good understanding, but now the data is very mature. The estimated risk, regardless of presence or absence of family history of prostate cancer, is listed here. Germline means inherited. About 12% of patients will have some form of DNA repair mutations. And then in terms of acquired means it just happened within the prostate cancer cells as part of stress to DNA is up to 20% of patients. So if we don't test, we don't know. All right. And in fact, a group of us came together in Singapore a few years ago and published a recommendations where patients with metastatic prostate cancers should have genetic testing done to select the best treatment and understand the cancer biology. Typically, their cancer is more aggressive and they need to have additional treatment. So how do we deal with this information? If we find a patient with positive DNA repair gene mutations, we will add targeted therapy in the form of PARP inhibitors that target DNA repair genes on top of other usual treatment that we use. And this will be in various combinations depending on which disease setting that they are in actually. So in the last 5 minutes, I'm going to talk about prostate cancer survivorship because surgeons and radiation doctors are treating the localized treatment very well. We are also treating the metastatic cancer very well. Patients live longer. Now they're going to potentially live with some side effects. Okay, so first thing that may be troubling our patients is sexual function. So treatment or cancer itself may lead to erectile dysfunction, lower libido, problem ejaculating. But before we blame cancer completely, erectile dysfunction happen in general population. There are long lists of causes of erectile dysfunction, and cancer and treatment is just one of the less commonly. So if you get older, you're going to get more chance of issues, chronic medical conditions, be it diabetes, hypertension, heart disease, bad lifestyle habits, smoking, alcohol, obesity, sedentary lifestyle. All these has contributions to erectile dysfunction, not to mention medications and psychological issues. But how does prostate cancer affect sexual function? So the diagram on the right illustrates bladder as the biggest red thing, prostate as a purple thing in the middle, and the base of the penis as the tubular structure. The yellow thing is the nerves that control erection, and you can appreciate it's very close to the prostate, which is in purple. So any treatment directly targeting the prostate runs a small risk of affecting the nerve. Okay, and if the nerve's affected, obviously after treatment, there may be issues with sexual function. The chance of preserving erectile function after treatment is influenced by obviously pre-treatment sexual function. If they are already affected even before surgery or radiation because of age, other health issues, or the size of the cancer alone, the likelihood of retaining sexual function after treatment is not high. Conversely, if the tumor is small, then nerve-sparing approach, robotic surgery, all these have reasonable chance of preserving erectile function. Now, drug treatment itself also affects sexual function, because by nature of drug treatment, we want to suppress testosterone. We do not want testosterone to drive the cancer cells. When you have lower testosterone, you're going to have the effect of reduced sexual desire, erectile dysfunction, and even long-term wise, after a few years, you may see shrinkage of testicles. How do we help with some of these issues? We have to think about who needs prolonged hormone suppression, who can get away with shorter duration safely. Then there are other medications such as Viagra, Cialis, and then devices or implants that our surgical colleagues may help patients with on top of couple counseling. The other thing is androgen deprivation therapy not just cause sexual function issues. There are other issues that come along with it, especially if patients are on this class of treatment for a few years. What we commonly see is like male menopause. Okay, so we're going to see a change in body shape, impaired glucose tolerance, the diabetes flares up for those with pre-existing diabetes, cholesterol goes up, weight gain, blood pressure goes up. On top of that, we're going to see earlier bone loss. Just like female, when they go through menopause, they're going to have accelerated bone loss. We're going to see shrinkage of muscle mass. Okay, and then some of them may have hot flashes. We have patients who sit in front of our consult room with a small handkerchief wiping off their sweats because of some of this exaggerated effect of ADT. Now, how to address some of this? I think active, healthy lifestyle will reduce some of these. Okay, so you have to continue exercise, maintain muscle mass, and then there are some medications that we can recommend in select case to help with bone health and other issues. So in conclusion, we talk about prostate cancer in localized setting, in metastatic setting, but even within that, there are different scenarios that we have to take into account. I didn't have time to talk about this entity called oligometastatic, where the cancer spread, but only in 2 or 3 sites that can be approached with a much more aggressive approach. Patients with high-risk localized prostate cancer can be treated with curative intent, but before that, they should routinely consider an accurate PSMA PET as part of staging. And all these patients with metastatic settings should have genetic testing to detect DNA repair defects as part of our recommendation. And for select patients, we should think about appropriate treatment intensifications to achieve the best long-term results and minimize long-term side effects by careful monitoring of toxicities. Thank you.
Thank you very much, Doctor.